many of you have SNS and CRI responsibilities. I'm wondering how many of you have thought about your medication center effectiveness with getting the right medication, the right dosage to the right person. In October of 2010, during a day-long Project Homeless Connect event, we partnered with the event organizers, MRC, and our nursing students from a local university. There was a large venue, a large number of members and staff that could help with our throughput. For this exercise, we decided on an anthrax incident with two major objectives: 1,000 per hour throughput with a 90% accuracy rate. Folks entered into the medication center. They were screened to determine the appropriate table. They were dispensed their medication and their information sheets, and then they exited. We used this diagram also to assist with the training. The pod group supervisor conducted just-in-time training to 55 staff, and then they broke out to role-specific leads that gave them additional training. The screeners received the training that stressed the need to assure the right people get to the right tables. The blue table was doxy only. 10 dispensing tables were staffed by nursing students, and just-in-time training was given by the pod group, the dispensing lead, who was a nurse. It was also stressed there that it was one patient at a time that they take care of the medications. We had 2 hours for our exercise, so we mass-produced our forms. We distributed them, had them all filled out. We followed the 2002 guidelines in the American Society of Health System Pharmacists. In addition to the two major objectives of measuring throughput and accuracy, we also wanted to evaluate our algorithms, our just-in-time training, our head of household forms, and to see whether a non-medical model really worked. Although we saw roughly 1,600 people with a throughput of 800 an hour, we felt that we would easily reach our first objective of 1,000 an hour. There were people that were cycling through and running through the lines. However, our second objective, we fell short. So the errors that we saw, doxy would given to the people that were allergic as well as pregnant and breastfeeding women. Many pediatric dosage errors. Wrong number of doses per day for our renal patients. And there was no medication label on our screening form. If it wasn't documented, it wasn't given. As you can see, we fell within the adult rate of 10% for our adults, woefully short for our children's rates. And the majority of those were doxy errors. This was our first response. We still have traumatized staff from this exercise, but we had a lot of work to do. We knew we had to get going on it. So we went back to the nursing students, we went to the Medical Reserve Corps, and we asked them for their help. What did we do wrong? What were our errors, and how can we fix it? And we did go back and redesign our forms, our algorithms, and our training. So we said 8 years and under, instead of under 9. That correction alone would have taken care of the majority of our doxy errors. We color-coded and bolded on our algorithm. We used vertical lines instead of horizontal lines on our algorithm, the yes and no columns separate, and we wanted to make sure we did one patient at a time. This is our blue dispensing tree. As you can see, the yes and no columns separated. Color variations on the bottom to signify the dosage differences. Yellow font as a focus or caution. We strongly emphasized in our just-in-time training for our screeners these 3 points. And as you can see here again, the bolding and the coloring as visual cues to help bring the eye to where you want them to see. Our next decision tree was yellow. Left was the blue, yellow on the right. Again, the color shading on the bottom to signify the dosage differences. Red for stop or caution, and then the vertical lines. Our third decision tree was for our renal disease patients. And here again, if we could not accommodate them in our medication center, we triaged them out to pharmacists or to physicians. Color coding here as well. In the future, we plan to use dispense assist, but because we have a non-medical model, we recognize we will still continue to need to use algorithms, and we need to ensure that those two are in alignment with the dispense assist and with our algorithms. So we strongly encourage you to look at your, in future exercises, to test your error rates, take our learnings, and remember that it's just as important to get the right medication to the right person in the right dose, and it's just as important as your throughput. Thank you for listening.